right, I don't want, you know, you go home without any of the information, but she seemed to just want to get her out of there. And, even when the mom questioned the med, I feel like she should have gone and looked into it, but she just kind of swept it to the side, let them go.
Yep. So the way my mind works is I'm thinking about the art and the science piece again, because I guess that's just how I always do everything. And I'm thinking about all the things she didn't do that are like evidence-based procedures that she didn't follow. But then you brought up about how, you even gave an example of how you would approach the mother and how you would change the situation, and you used your own flair and your own style of how you would say it. You're efficient, but kind, and you would explain the importance of it. So that was a really good example of mixing that and how you use your own approach.
She assumed she could read.
That's a good one. Yeah. Yeah. So there's one safety thing at the very beginning, and it really isn't involving discharge planning at all, but I just was caught off when I saw the answer key. I didn't pick up on it, and it's staring us in the face.
So it's that
yeah, and I was like, how could I miss that? But again, so if you were in the room, I think it looks strange when you think about it. It's like, oh yeah, that's not how we do things. But I thought that was interesting. So that's our family that went home with very incomplete instructions. So I'll touch base on where everything is located in Power Chart. And remember that the part of this is that you can get signed off on your competency for knowing how to manage the transplant discharge teaching checklist. So this is a little piece of that, just so that we know where everything is. So maybe what we could do is maybe go around the room and quickly say where this is found. So the hospital policy for discharge planning, which actually is one of your handouts. Does anyone, oh, you can just raise your hand. Does anyone know where that is found? E-library, yeah, good. And then the nursing discharge note. Yep. And patient care referral. So what if it's not started yet? Very good.
Education discharge.
Yeah. And then the provider discharge summary that often you need to print for an agency or services.
Just a provider discharge note.
Yeah, you can do that. There's a couple of ways to go in there.
Viewpoint.
Viewpoint. Yeah.
Viewpoint.
Perfect. Yep. Where are we? Okay, the transplant discharge teaching checklist. So what if there isn't one started yet? Yeah. And does anyone remember what it's under?
Transplant education.
There you go. Very good. And then if it is started, good.
Click on the one that's already been started.
That's right. Don't start a new one.
Check to see if this one's
Very good. So the education tab, we all know where that is. Does anyone know where the case manager notes are?
Yes, under documents, there's a separate section that says case management, and under there will be notes.
Yep.
But you can also sometimes find things under discharge, and then, it sometimes says supplies and planning and supplies, or something like that. Sometimes there's notes under there as well.
Yeah,
So the forms browser.
Forms browser. So there's multiple places. Yeah, and then related to that is the discharge community agencies to see the listing of that. Right, exactly. And then I learned this recently, that you can see outside pharmacy services. This is new. This was new to me, and right now I couldn't even. I would have to look. So you can actually see other private retail pharmacies that they've gone to with what prescriptions and dates and things like that. So that can be really helpful. Obviously.
How do you do that? It's in the. I think it's in the gray bar up top. It says
Patient pharmacy.
It's near when you're doing the med history and the med reconciliation. It's up in those tabs.
And it's also, you can get it from anywhere in Power Chart on just the regular gray banner bar, where you could get like LexiComp or anything like that too.
Oh, good to know. You can have a demo later. Thank you, Lauren. So, and then of course we talked about the medication history and reconciliation, which is critical towards all of this, discharge planning and safety and everything, as we all know. Okay, and then the last thing that I'll just bring up quickly is the patient care referral. So, you know, people do these in different ways, and often you see them sort of not so complete. So in order to have a really complete, full picture, think about a nurse that's gonna go in the house and take care of a patient that she never met. So she needs orders, first of all, and that's what the discharge summary will give, is orders, and that's why we have the patient care referral signed by an actual provider, because all of those instructions are actual orders for them. So everything should be there, that just like you would want in Power Chart, they need to see everything. So obviously the identifiers, allergies, date of admission and discharge, the attending's name, and then the primary care provider's name, and they usually have the contact information, the address for the PCP. The agencies, the admitting diagnosis, the discharging diagnosis, the medical history is there, and then the summary of what happened during the hospitalization. And then you'll have nursing physical assessment by systems, which is done by the nurse. Some people do it and some people don't. But that is really important as far as when the nurse goes in and does a physical assessment, they need to know if there's something different than what's happening at the hospital, of course. Contact information for, again, who to call if something goes wrong. Reasons to contact, so the nurses in the home and the services need to know the red flag reasons just like the family does. And then of course you need a signature from the provider, and it's good to have the name spelled out and the phone number and all of that. So those are the pieces of the patient care referral. It's a lot of information and they take a lot of work, but it's not a lot of help for the nurses going in the home if they're not done in a complete way. All right, so where are we now? We are going to let's talk about discharge teaching. Because it's a nursing thing. We can get up and dance now if you want to like stretch your legs. I like this one, from my time. So nursing and discharge teaching is definitely owned by nursing, and it's on us, and we're the experts, and no one else can do it better. So let's see how this nurse does with nursing discharge teaching.
Good morning, AM shift. As a nurse, we wear many hats. We have our hard hat when times get rough. We have our baseball cap when we have to do our coaching. We have our beret when we need to get artistic. And we have our glasses for all the teaching that we have to do for our patients. As nurses, we are constantly teaching, and sometimes we get in a hurry and don't realize the importance of what it is that we need to tell our patients. We rush through because we've had a long day or are behind in task. The patient says they understand while rolling their eyes, and they know that they shouldn't drink anymore, and we move on. 1 month later, when they're back in the hospital with an additional complication, we're kicking ourselves in the behind for not doing the thorough teaching the first time. Here's an example of bad teaching. Hi there, I'm Brittany, your nurse. You seem a little sleepy and a little out of it, but I'm here to do your teaching. I saw in your history that you've been smoking for 30 plus years, but I'm going to need you to stop today because it's making your condition much worse. Maybe you should start taking some nicotine patches or chewing the gum. Also, I saw that you drink the day before football games and on game day, and then have a beer on Sunday to cure your hangover. I actually do the same thing. But anyways, I'm going to need you to stop that as well. And last but not least, do you know how to use your insulin pen? No? Okay, well, it's getting a little late. I need to make some more rounds, but here's a sheet of paper right here. I filled it out for you. It's just 15 pages. Just buzz through it, and if you have any questions, just buzz the nursing station. Oh, and your Dilaudid should be wearing off in about 20 minutes, so I'll be back to give you some more. Okay, so this was a little dramatic, but you get the picture. It's wrong. We need to be our patient's advocate so that they learn to trust us to help them make the right decision. We need to make them realize that what we are teaching them is very important for their recovery. Everyone learns in a different way. Some learn by reading material, some learn by lecture, some learn by interaction and hands-on. We need to acknowledge this from the beginning and accommodate for their needs. If not, this patient that you're hoping leaves today because he's been buzzing the nursing station every 3 minutes, guess what? He's going to be back. And you know why? Because you, along with several others, did not teach him how and when to use his insulin and how to empty his Foley bag. Also, you didn't stress to Miss Susan in room 4 that she was supposed to wipe from front to back, increase her fluid intake, maybe take some cranberry pills once a day, and most importantly, finish her prescription of antibiotics. Now she's back in the ER for the 3rd time with another kidney infection. This is no fun for her, and she's about to make her day even better. Had you educated her properly the first time, maybe you wouldn't know every person by first and last name in her family. It takes 5 to 10 minutes if you are focused on getting the job done. Teaching takes repetition. Get over the fact that you will have to go in the room tomorrow and reteach the exact same thing. This is your job, so do it right the first time. Because time is money. You will go home feeling proud and less concerned, and they will go home with the knowledge that can save their life.
Brittany, she's a little preachy. Time is money, but she made her point. So I don't have to ask you all the different problems. She pointed them out. Of course, you wouldn't give discharge teaching or any kind of teaching to someone that's still, sedated. So yeah, lots of problems. Maybe her role model is Nurse Jack. So let's see, what will we talk about now? Let's talk about quickly adult learning. So this is important because the people that we usually teach, other than if the kids are part of the teaching, and then if they're teens or young adults, of course, they would be part of the teaching, but usually it's the parents. So we have to understand how do adults learn. So for me, it was really important because you get so used to talking to kids like the way you talk to kids, and we're so good at that. And then you have to switch gears and sort of think about, well, what's the best way for an adult to learn, and how can I approach this complex topic with this parent? And then you have to look at all the different obstacles too for that particular family. So this is just a little bit of theory about, sorry, music again. It's a little bit of theory about, hopefully, yeah, here it comes, about adult learning. That was a surprise to me. But not to me personally, but other people. I don't remember anything. So what we hear, only 20%. Of what we see. Jordan was cut from high school basketball. What we discussed. So you can see how these theories align with the way that healthcare now is using simulation, even with parents. So now we're incorporating simulation sessions for parents to learn skills and care at home. So you can see how these are the reasons why. Because just talking at them, they're not going to remember it. And then you add more and more sort of sensory stimulation. Same thing for professional development. If I just stood here and talked to you, you would fall asleep and you wouldn't remember any of it. But if you throw in some interactives, so for adults, you need interactive activities, you need to get them engaged, you need to have them understand the reason why they're learning it, like how is it going to help me and how is it going to help my patients. So I thought that was really helpful for me to think about when I approach a family and I'm trying to teach them skills and information, what kind of things. It's good to have pictures, it's good to have, if you have a video, we're doing the transplant class now that has some visual and some audio. So these are evidence-based practices, and, it's really important so that learning really, works.